So let's get started, because the sooner we start, the sooner we get out. Let's talk about biologic casualties, okay? We're going to talk about the various biologic agents and how to recognize the signs and symptoms of those agents. These also have been around a long, long time. You may remember back in the Middle Ages, they would take the bodies of plague victims, catapult them over the walls of cities they were laying siege to in the hopes of infecting the population, make it easier to take the town, okay? I mentioned the smallpox blankets that were given to the Indians by the British. Germany in World War I had a very active biologic program. In fact, they sent several spies here to the US with a biologic agent called glanders, and they were hoping to infect the horses that we were sending over to Europe. They actually got captured before they infected anything. And then Japan, of course, had a very active program in World War II, just before World War II in China. They actually, you may have heard, they would drop infected fleas in China with plague in an effort to infect the population there. And then we continue to have biologic programs that have continued by a number of countries, okay? The ideal biologic agent is one that will get caught in the lungs to produce disease, okay? So that means if you want to make a biologic weapon, you have to make the biologic the right size. If you make your particle too big, that biologic is going to get filtered in the upper air passageways. It'll get lodged in the nose and the pharynx, okay? It may cause localized disease up there, but it'll never get down to the lungs to cause systemic illness. If you make your particle too small, what happens is you'll breathe in the infective particle, but because it's so small, it does not get stuck in the alveoli of the lungs, and you breathe it right out again. Once again, we don't produce our disease. But if you make the particle just the right size, you breathe it in, it gets stuck in the alveoli of the lungs, and now we have the chance to produce the disease that we want. If you think about the anthrax letters that were sent here in the US in 2001 or so, okay, that anthrax was like 90% the right size. So whoever made that stuff knew what they were doing, okay? This is a slide we got from the military. If you were to take 110 pounds of anthrax spores, throw them into a crop duster, spray it along a 1.5 mile long tract in a city the size of Denver, you could kill 24,000 people and hospitalize probably twice as many, okay? And then obviously produce a lot of psychological impact as well. We also got this from Northern Command down in Colorado Springs. This is a simulation that they developed of a plague release in a casino in Las Vegas. So it's a Friday. Our terrorist releases plague into the air conditioning system of this casino. 600 people are exposed, okay? Saturday, some of those people fly home, okay? Sunday, some more people fly home, and now we're starting to see some complaints of illness, okay? The red dots represent people who are starting to get sick. And it's not just here in the US, it's in foreign countries as well if there were some international travelers, okay? Monday, more people are flying home. We're starting to see more cases of illness. Okay? Tuesday, more people fly home. More illness is reported, and now we're starting to see secondary cases, meaning person-to-person transmission. That's what the green dots represent. And the size of the dots represent, borderline numbers, okay? Wednesday, more people fly home, and this is what it could look like, okay? This was actually modeled by these guys. This is not an out-of-hand scenario by any means, okay? So, these agents, depending on the bacteria that you pick or the virus that you pick, this is the sort of scene that we could be faced with in a matter of days, Okay. Well, what are we looking for when it comes to a bioweapon? We're looking for the sudden onset of large numbers of people with a similar clinical illness and a high fatality rate. Okay. All of these agents, all of the ones we're going to talk about, they all start out like the flu. So fever, chills, aches and pains, and then they go on to die, essentially. Patients who are immune compromised, HIV, if you're a transplant patient and you're getting therapy to not reject your transplant, okay, the immune compromised patients, they may be the first group of patients who get sick, okay. We look for diseases that we don't normally see in a particular area, okay, or an unusual seasonal incidence, okay. Maybe multiple outbreaks, but dispersed geographically. Sick or dead animals, common problem, okay. In fact, how did we recognize West Nile disease? Sick birds, okay. Recognized by a vet in New York State, and it was sick and dying birds, okay. That's the clue that we had for that disease. Travel history, obviously important for some diseases, notably things like Ebola, okay. Contacts, employment history, etc. Important information. Biologic agents fall into three large groups: bacteria, viruses, and toxins. We'll mention a couple of each, okay. The CDC has characterized these things in terms of how deadly they are and how easy it is to weaponize them, okay. So the category A agents, highest priority: smallpox, anthrax, plague, botulism, okay. Viral hemorrhagic fevers, that's diseases like Ebola, okay. The others lower down on the list, the category C's, harder to weaponize. So let's talk about the bacteria. Bacteria in general, single cell organism, they invade tissue, they either produce toxins or they cause inflammation. They may produce spores. What's the important thing about spores? Is that it makes them last for a long time. The bacteria can survive all sorts of terrible conditions if they form spores, okay? The notable spore-forming bacteria that we deal with is anthrax, okay? Anthrax is an infection that is essentially everywhere in the environment. It's out in the dirt. It's endemic in animals, okay? We see a case every so often in people who handle the hides or the body fluids from infected animals. It's called wool sorter's disease, okay? If you ingest, inhale, or inoculate into the skin the spores of that bacteria, our immune system will attack the spores. It'll send white blood cells and macrophages to attack the spores. They gobble up the spores. They carry the spores to the regional lymph nodes. Once the spores get there, the bacteria become active. And the active bacteria produce 3 toxins, okay? So it's not actually the infection that gets you, it's the toxins. The first one, excuse me, is edema factor. No big surprise, it causes swelling, okay? Second one is lethal factor. Lethal factor kills cells. And the third one, which to me is the most interesting of the 3, is protective factor. What it does is it prevents us from neutralizing the other 2 factors, okay? Inhaling has the highest mortality. So inhalational anthrax, highest mortality. Obviously that would be the route that a terrorist would want to use, okay? It causes a mediastinitis, meaning the lymph nodes in our mediastinum get infected, they swell, okay? That's the mediastinitis. You can get it in your skin. You can get cutaneous anthrax. You can see that has a 20% mortality if the patient gets septic. If we recognize it and treat it, mortality is only 1%, okay? Our clinical picture: sudden onset of respiratory distress preceded by the flu, mediastinal widening on the x-ray, okay? That's the classic. You may get GI anthrax if you ingest it. You may get cutaneous anthrax. I'll show you some pictures. We're going to diagnose it by gram stain of the blood, but it's usually not an early finding. And then there's other lab tests that we can do. These take days to come back, not a help. Okay. There is cutaneous anthrax. The picture on the left, you can see that left orbit, very swollen. You see that dark spot, okay? That's the dead necrotic tissue. That's lethal factor. The swelling is from edema factor. The right-hand picture, look at that kid's face, okay? Half his face is swollen. You can see the lesion just below the lower lip there, to the left of the lower lip, okay? That's the necrotic area. Tremendous swelling as a result of those hot toxins that are formed, okay? Here's cutaneous anthrax in the neck, okay? Big necrotic lesion. The swelling at this point has gone down a bit. Here it is in the arm, and you can see how long it took for that to heal. 6 to 8 weeks, okay, with treatment. There's GI anthrax, oral anthrax. Left-hand picture, you can see the lesion just beginning there in the back of the throat. Okay, right-hand picture, you can see how large that lesion has become. That's all dead necrotic tissue. Here's inhalational anthrax, okay? If you take a look at this x-ray, what you can see is there's the mediastinum. These are all swollen lymph